So welcome, Julika, to this short-term, high-impact discussion today.
Thank you, Olga, for having me.
Would you like to introduce yourself?
Yes, my name is Julika Hudson. I'm originally from Germany, but I'm based in Ireland, in Dublin, and I'm a midwife. And I have recently started my PhD work with Trinity College in Dublin here.
Right. So, what is the scope of research that interests you the most in general, and why you chose to focus on this specific item we are going to speak about a little bit later?
Okay, so I'm generally was working as a practicing midwife, and I'm very much interested in midwifery research and in anything that is kind of improving care for women and families, I suppose. So I was very lucky to join the Cost Action through my supervisor, Professor Joan Lawler, and at the stage that I joined, and I actually did this SDSM as a first step. I was at the beginning of starting my PhD, so I was still trying to kind of get an understanding of what was important and what kind of research might be needed. So when I was joining in September 2020, we were still like in the midst of the COVID-19 pandemic. So COVID obviously had spread across the globe, highlighting quite some inequalities, and the Cost Action did a lot of research on that. So I followed that with interest. And I felt that I think Drandage and van Leuven described it as a watershed moment for birth rights. And they were kind of saying that COVID would either highlight problems in maternity services and then hopefully bring forward change, or it would like kind of further give rise to the abasement of women's rights in childbirth. So I felt for me that was something that I was very concerned about. And while I understood that restrictions in maternity services that we were dealing with at the time were obviously there to kind of protect the population, we very quickly saw that there were very stark differences between the different responses in the different countries, and especially in Ireland where I worked, there were differences within the 19 maternity units across Ireland as well. So the WHO responded very quickly, and they established guidelines to kind of balance the effect of these restrictions. And what came out when we were kind of looking at the research that was done at the time is that there were still differences in the adaptation of these guidelines, I suppose. And we know as clinicians that decisions always must be kind of based in evidence, because any interventions will have long-term implications for the mother and the baby and the family unit. So in Ireland, we were particularly concerned about kind of that there was no clear governance of these restrictions, and staff morale was quite low at that time as well. Now, in fairness, Ireland had issues before COVID-19 as well that I, as a practicing midwife, would have experienced. So we have a very centralized maternity system, and a lot of fragmented care for our women and families. So the solutions proposed, they often lack focus on like the experience of care, which is something that, again, for me as a midwife was very important, that we actually find out what would women and families find important and what would help them to kind of have a good experience and a good start to their life as a new family. So I was in my research looking at kind of how the right to informed consent and the informed declining of treatment was kind of navigated by pregnant people in Ireland. Just before COVID saw the establishment of the National Maternity Strategy, which was there to improve the services or service experience for women and families. But the problem with that is that the National Maternity Strategy was actually written cognizant of Article 43.3, which is an article in the Irish Constitution that until 2018 gave equal right of life to mother and fetus. So that is quite a unique situation here in Ireland. And while it wasn't targeted, I suppose, its provision of maternity services, it definitely had like an impact on how we provide maternity services here. So because of the legal change, the HSE had to change its consent policy. And the consent policy now firmly establishes a woman's right to informed consent and to informed declining of treatment in pregnancy and birth. So that was kind of the situation that all of this was happening at. So I then saw in the research that Iceland had been identified as one of the countries that most closely aligned with the WHO guidelines. And they continue to provide evidence-based care to women and families. So for me, it was really interesting to kind of find out, okay, why did Iceland succeed in adapting these policies so quickly and successfully? And why did we have such a disparity in reactions and restrictions in our maternity services? So I was lucky that through the cost action, I was able to then meet with the Icelandic midwives, and I want to give a big thank to Inga, Hildur, Sia, and Katrin, who shared kind of their knowledge with me at that point to kind of see why Iceland maybe had a different reaction to COVID compared to Ireland, and what we can learn from that.
Splendid. So you went to Iceland in order to observe and learn what is it that makes a difference and bring this understanding back to your country. So actually, what did you observe there? How would you list, what would you list as the most significant understanding of what creates such a difference?
Yeah, so in Iceland, there appeared to be no blanket ban on their maternity services. So there seemed to be established relationships between midwives and women already that allowed for like an individual estimation of the situation rather than like a ad hoc overall ban of services. And therefore, women seem to have continued support in their pregnancy and during birth. And it was kind of more like an individualized measure than like an overall for everybody, one fit all reaction. And the other thing that kind of came out of my communication with the midwives was that Iceland also has a very strong midwifery voice, which they felt it was strongly connected to education. And the one really interesting thing that I thought was actually they had a change where to Icelandic midwives now have to have a nursing degree as well, just because of the geography of the place, that sometimes in the smaller units, you know, you wouldn't have a post for midwives, so they would have to be employed as nurses as well, and then work as midwives. And that was really interesting personally for me, because coming from Germany originally and having done my midwifery here, I always felt that Ireland was lacking the midwifery voice because for years you had a nursing degree and then you did your midwifery on top, rather than having a direct entry midwifery program as it is established now. So I thought it was kind of still the effect of that. But speaking with the midwives in Iceland, it became clear that actually, you know, it obviously must have not been the reason. And I thought that was really interesting that they were able to be nurses and midwives and still have that really strong identity of a midwife. And in Icelandic, I thought the beautiful thing that I learned was the midwife is called the mother of light. And it just seems to be a very accepted profession. And so what I found was that there's a strong collaboration of the multidisciplinary team. And they were talking about non-blame cultures and shared responsibilities. And the midwife in itself is just a very accepted practitioner by everybody. So it's known by obstetricians, by any other profession that, you know, this is the midwife's role and that's the scope of the role of the midwife. And they're able to practice within that, which I think is really important. So when they qualify, they get a certificate that states they can practice in any setting they like, which is something that is very different here in Ireland. So that was kind of, it became an idea as well that the education, not so much the midwifery education, but also the education of the public and of other disciplines had led to that stronger belief in a midwife. And then everybody was also talking about the women's strike in 1970. There was a strike for equality in Iceland, and haven't seen their mothers or grandmothers kind of going to the streets demanding their equality. I think it had a real impact on people, and for me it showed that there's this community or like this understanding across the public that demands something, that accepts that, you know, that women have rights and that they require support and individualized care in pregnancy and birth as well.
So, what what are the key understandings that you brought back as proposals for the Irish environment to adopt in order to improve or learn from the Icelandic example?
Well, it was really interesting because when I did this in 2021, and then in January 2022, the restrictions across Ireland were lifted. However, I started doing research here within the maternity services in June 22, so 6 months after that, and women were still telling me about restrictions in maternity services. So they still exist. And now we're now in 2023, and in April 23, we had the last kind of mandate of masks in hospitals. That kind of was dropped as well. So there was quite an outcry again that there is still units that have partner restrictions in, yet people don't even wear masks in hospitals anymore. So it really shows that maybe it went beyond just COVID, and that there's a problem of the structure of our maternity services, how it is done. And I think this is the important part where we really need to look at, if policies and guidance documents dictate staff practices, they're barely social coordination mechanisms rather than based on evidence and law. And I think it's really important to understand that sometimes that they're not necessarily evidence-based just because they're in place. And I think it's really important that, we look at continuing to call for transparency, because the inconsistencies that remain within restrictions really have an effect on women here in Ireland and their families. And especially if you're looking at marginalized groups, they're at a greater risk again, because they might not have the language or the knowledge to question the restrictions that are given to them. So anything that is done just in case, and the convenience for the staff or the organization, that's not good enough. And I think we're at a point where we really need to understand it's bad practice and it shouldn't continue at that level. So I think it's really important. So that kind of is what I came back to, a continued kind of continuously seeing that yet COVID restriction overall were kind of decreasing, the inequalities in maternity services and the way we're doing things still kind of remain very untransparent. And
is it all right if we assume that this malpractice issue that came up so evident, so obvious during the COVID period was nothing new or is not a new thing, but it existed even before COVID, and it is just that COVID exaggerated some phenomena that already existed in the health systems? And if yes, could you speak a little bit about this?
So I think from what I've seen in the research and my own research, from what I've heard from women, that it is definitely like that's a structural issue around how we provide services, and it's a very kind of it's like fragmented care. It's very centralized, and there's very little room for individualized care, which is just really important for women and families. And so I do think women talk a lot about feeling isolated, feeling vulnerable. We're already before COVID had an issue with raising rates of induction that has been again accelerated through COVID. And as we know, that does have long-lasting impact on the whole family unit, and should not be done lightly if there's no medical need, I suppose. So there's been a recent study now that with over 180,000 women, and it showed again that induction of labor is not associated with better perinatal outcomes. So I do think there is a lot of questions to be asked about certain practices that kind of seem to remain in our services. So yeah, does that answer your question? Sorry.
Yeah, all right. So there are things that need to be done in order to improve the situation. Do you personally think that this COVID way of functioning is history, or we are still in the situation perhaps a little bit different we were in the previous years, or have we learned some lessons? What do you think?
I think with regards to learned lessons, I think like it is like, the positive change is yet to be seen. I think we learned, there was lots of research done, and yet somehow there's that lack of translating that research into practice. And I think that is the main thing that I've learned also from my exchange with others and through the network, is that, it is, as much as it is about doing research, it's also about translating the research across the board, because otherwise you're often finding yourself kind of preaching to the converted already, like it's, like if it's always staying in one time. So I'm really grateful because I have gotten the opportunity within COST to work with the working group 6, who's looking at the output. So doing exactly that, kind of trying to translate research outcomes so that the public can access it. I suppose what the STSM has given me is that it's given me a little bit of hope that change is possible, because the outlook in Iceland initially was different as well, like structurally. And I think the change that is possible, it needs to come from the wider public as well. So for me, it is about increasing the communication, looking at ways of like maybe public patient involvement in research to kind of really grasp that understanding of what is important to women and families, and how we can make a change that actually is effective for them. And the point of education is another one that has come out. And I think education then, in that sense, it's important with regards midwifery education around other disciplines, so that they become aware of what a midwife could make us a difference. And then also education of the wider public from an early age on of promoting the role of midwives. So I think that's really important.
So actually you speak about the rekindling of the hope and positivity when you are in environments that already experience what you wish for your country. Then you speak about the need for translating all this knowledge gained into strategies for the benefit of families, individuals, children, and country societies. And you speak about adapting so that we can include more trans or multidisciplinary education, which will be available to students or to various levels of education. And you speak about the need for cultivating this positive image of the portrait of a midwife in the society. Right?
And I think that's really important, yes. And I think like that is maybe one thing that I've learned, you know, in Iceland, it's like the mother of light. It's like it's already such a beautiful picture or image that you can see. And I think it is something about being a professional and having gone through the education to become a midwife. It gives you scope to really support women and families, and I think it's really important that we kind of utilize that, because otherwise it's a real waste if we don't do it. So when we see in COVID, often community midwifery was kind of drawn into the centralized services. I feel in Iceland the individualized kind of continuation of care was a better response, and it gave kind of room for that individual assessment of what is needed here and what are the risks to that particular woman and that particular child. And you know, it is very hard to do that at a very centralized level where it's, you know, so where everybody goes through the same net then. So I think, like, you know, if we accept the role of the midwife and actually let midwives work in communities and be a part of life for families, that would be a good thing. But also it would have been great, a better response, I suppose, to COVID could have been possible, maybe, if that was the case.
So actually you speak about a different direction now, because in the past we went too much central direction to the center, gathering midwives, etc., to a hospital somewhere centrally, forgetting perhaps the community elements like community midwives of the past. And now we realize again that it is important to go back to the community and move away from centralization to the periphery, and perhaps a good balance between the two might be a possibility.
It would be great, because it is like, obviously there's challenges to both, and there's challenges also to, like, you know, if you want to implement evidence, I suppose you want to have that evidence across the board. So you're looking at some, like, at a bigger level. But I do think that the individual risk assessment and individual assessment of what is needed is really important. So it is kind of trying to bring those together and see how it best works. But I do think it's a sustainable model that would certainly lift a lot of pressure off our centralized systems that might function better than, again, if it didn't have the weight of everybody going through the same thing and unnecessary interventions.
So, after the experience you have gained, what would be your message to the policymakers, including the decision makers, not only in the ministries of health, but also in the management of hospitals, maternity spaces? What would be your message to these policymakers?
I think my message to the policymakers would be that it is really important to look at the vast evidence that we have for midwifery care, for low interventions in pregnancy and birth, and what the long-term effects on unnecessary interventions really are. And I think for policymakers, it's important to kind of adapt these as best as they can in their policies and make sure that really, you know, they try to base it on what research is there, and that there's more connection, and that there's maybe more communication between policymakers and researchers as well, together with the public who these policies are for. So I think it's at the forefront that the all stakeholders kind of come together and speak about how that best can be implemented, and not just policymakers or researchers, but also the women and families that will experience the care at the end of the day.
Excellent. And your message to other colleagues in other research groups, perhaps doing similar work, or perhaps closer to the subject, what would be your message?
I think, like, it's really important that we look at the research that we have, and maybe also see why sometimes it has not been implemented, and what is kind of what's holding that back. And so that in future research, we make sure that we take that into account and make it something that is adaptable and that can be adapted by policymakers, and that can actually have an effect on women and families. I think that's really important, and that maybe, you know, sometimes we need to look at the ways we're doing research and how it can be maybe made more accessible as well.
Right. And finally, what would be your message to the stakeholders inside or outside? What would be your message to them? Midwives, or mothers, or family members, social structure. What would be your message to them?
I think it's really important that we can have open communication channels. I think communication is key, because we're all coming from different backgrounds, from different sites, you know, we all have different perspectives. And that is one of the things that I've learned through COST, or that I had the benefit of experiencing as well, that I was able to see different perspectives. And I think, you know, sometimes when we're have questions around practice, you know, very quickly it becomes that blame culture. You can feel like you're being put in a corner where, you know, you might be blamed for something. It's not about that. If we can't talk about it, we cannot improve it. So it's not about what the one person is doing. It's what we together can kind of do better, I suppose, and how we can make it work better for everybody. I mean, it's not just women and families that suffer in our current organization of maternity services, but it's also, we have a high level of secondary trauma amongst clinicians. And I think, you know, it's really important that we acknowledge that, and that we speak across the groups, and that we try to find ways of improving the services for all of us.
Thank you, Julika, for this short-term, high-impact discussion.
Thank you, Olga.